Hello, everyone. My name is Tushar Chopra. I am the Associate Professor in Division of Nephrology at University of Virginia. With me is Dr. Monarch Shah, Second Year Renal Fellow and Chief Nephrology Fellow at UVA. And today we present this webinar on vaccination recommendations in special populations amongst dialysis patients, a case-based approach. Let's go over the learning objectives for this talk. We will try to understand the immune responses can be varied in special populations like end-stage kidney disease, discuss the COVID vaccine recommendations for end-stage kidney disease transplant patients who are on long-term immunosuppression, emphasize the importance of shared responsibility of nephrologists and primary care provider in educating their patients about appropriate vaccinations, and learn about the vaccine recommendations in end-stage renal disease patients who have a weakened immune system either because of HIV or solid organ transplants. And finally, try to understand the vaccine subtypes indicated in immunocompromised hosts. So with this, I'm going to start with the first case, and Dr. Shah is going to help me out with some answers. So this is a 58-year-old end-stage renal disease patient on dialysis secondary to HIV-associated nephropathy with a CD4 count of less than 200 and a percentage CD4 of less than 15, who just started highly active antiretroviral therapy and is new to in-center dialysis. He doesn't have a primary care doctor yet, and you see him on dialysis rounds, Dr. Shah, and he asks you, what vaccines would you recommend for him since he's new to dialysis?
Well, before I answer that question, let me take a moment to walk you through the CDC website's adult vaccine assessment tool, which is available online at cdc.gov. And all we need to do is enter the URL like shown here and hit enter, and then it takes you to the tool, which will then ask you some basic questions about your health. There are some questions that are shown over here which need to be answered. For instance, our patient in this case is a 58-year-old man and who is on dialysis. And just like you can see, he was born in the year 1965. He does not have any history of traveling outside the US. We are not sure if he has completed a polio vaccine series, and he does not live in a college dormitory or is not a first-year college student. So that's how you answer the questions, some basic questions. His medical history includes him having end-stage kidney disease, requiring dialysis, and HIV infection with a CD4 count of less than 200, which makes him highly immunocompromised. And apart from this, the list has some other clinical situations as well, like cancer, chronic liver or lung disease. And after all these questions are answered, you can click on the My Results button, which then takes you to the CDC recommendations page. So after answering all these questions and based on our answers put into the website recommends different vaccinations which are indicated in each of the scenarios. For example, this is a patient who is an adult and is 58 years old. So the COVID vaccine, flu vaccine, and the Tdap are recommended since he is an adult. And the shingles and Hep B vaccines would be recommended since he is 58 years of age. And considering the history of renal failure, hepatitis B, pneumococcal vaccines are recommended, and the fact that his CD4 count is less than 200 would by itself make hepatitis A and B, the meningococcal, pneumococcal, and the shingles vaccines indicated.
Well, thanks, Monarch, for that question answer and walking us through the CDC website. There is a follow-up question I have for you. Is there a varied response to hepatitis B vaccination amongst dialysis patients?
Well, despite the answer to that question is yes, but despite having a lower response rate to the hepatitis B vaccination in end-stage kidney disease patients, there is a greater reduction in the risk of a hepatitis B infection in dialysis patients. And the patients on dialysis can receive either a conventional or the conjugated vaccine. And as a result, the risk of infection is actually lowered by 70% in vaccinated dialysis patients compared to the ones who are unvaccinated. Seroconversion into anti-HBs antibodies is about 50 to 60%. And hemodialysis patients usually receive a higher dose of the vaccination. And the inactivated or recombinant vaccine confers active immunity by formation of anti-hepatitis B antibodies.
All right. And let's say there is a follow-up on this question, and his anti-HBs titers is still less than 10 million international units per ml after 1 month of the first vaccination series. What would be the next appropriate steps, Dr. Shah?
Well, after the vaccination is done, we should check for serologies within 1 to 2 months after the first series. And the patients who have titers that are less than 10, they should be revaccinated with an additional series. And once seroconversion is achieved, then annual anti-HBs titers should be obtained, and booster doses should be administered if the titers are less than 10 again. And despite an additional series, if there is no seroconversion, then we should check the surface antigen on a monthly basis. Another tip is that we can use an intradermal route for administration of these vaccines as to obtain a higher response rate. And we must all remember that the efficacy of the adjuvanted vaccine in non-responders has not been established yet. Well, Dr. Chopra, I do have a question now. This patient had a CD4 count which is less than 200. And are there any special considerations in terms of vaccination for that reason?
Yes, most definitely. And, the data is kind of sparing, and we have to go to expert opinion and consensus guidelines. And I looked up the IDSA guidelines from infectious disease that brings about this table where I want you to focus on the right-hand side, which is the high level of immunosuppression, which is what our patient qualifies as because the CD4 count is still less than 200. And just to give you some context, R represents recommended, U is usual, and X is contraindicated. And let's walk through this table. The Haemophilus influenza B conjugate is very age-specific vaccination, and it would be usually recommended up until 5. In a highly immunocompromised patient, it would be recommended up until 18. It is not really studied in adults. Hepatitis, yes, there will be recommendation to give the Hep B vaccine in a dialysis patient, but IDSA recommends giving the 40 micrograms of conjugated Hep B vaccine to a highly immunocompromised host. Not much difference in diphtheria toxoid, Tdap. Those are usual recommendations. But the human papillomavirus, IDSA recommends a quadruple vaccine because of its effect against genital warts in patients who are between 11 to 26 years of age or at a high risk population. Influenza vaccine, the data is pretty strong in recommending that inactivated influenza vaccine would be indicated in a highly immunocompromised host, but the live vaccine would be contraindicated because they have not yet mounted the CD4 count. However, in someone who has a CD4 count who has a low level of immunosuppression, like they've been on highly antiretroviral therapy for over 16 weeks, and the RNA plasma concentration is less than 60,000 copies, you may consider giving the live influenza vaccine, which is located here. But that's a weak recommendation with very low quality evidence. In terms of other live vaccines like MMR or the quadruple varicella, MMR would not be indicated in a highly immunocompromised host. And just to finish up the list, pneumococcal vaccine, usually conjugated pneumococcal PCV 15 or 20 is indicated in dialysis patients, but the polysaccharide pneumococcal could also be given in a highly immunocompromised host after 8 weeks of indicated dose of PCV 15. So those are the special recommendations that you would have in a dialysis patient.
Well, thank you for summarizing that for us. Let me take you to our second case for today. I have a 20-year-old first-year college student who identifies as LGBTQ with end-stage kidney disease from a failed kidney transplant and is seen on routine hemodialysis rounds. The patient continues to remain on low-dose prednisone and tacrolimus. He inquired about a LGBTQ-friendly primary care provider in the area and wondered what vaccinations would suit him.
Well, thanks for that interesting case. I we'll walk you through again the website, and these were the recommendations that would come. The adult, the end-stage kidney disease in age are pretty standard in terms of recommendations, but I wanted you to focus on the weakened immune system, and which is what qualifies you to get the shingles vaccine. Being LGBTQ, the hepatitis A vaccine would be recommended, and a first-year college student or a military recruit ought to get a meningococcal vaccine according to the CDC website. Now, Monarch, which vaccine subtype is safe in an immunocompromised patient?
Well, generally, all non-live vaccines can be administered safely to patients with an altered immunocompetence, and patients with most forms of altered immunocompetence should not receive live vaccines. But there's keep in mind that not all end-stage kidney disease patients have contraindications to receiving live vaccines.
Good to know.
And just so that we can complete a list of vaccinations that we should avoid in immunocompromised hosts, amongst that is the MMR vaccine, the varicella, the MMR varicella, yellow fever, rotavirus, typhoid vaccine, the oral typhoid vaccine, BCG, smallpox, and the live attenuated influenza vaccine. Now, taking the live attenuated influenza vaccine as a segue to the next question that I have for you, Dr. Chopra, is the flu vaccination recommended for patients with solid organ transplants?
Well, there are two parts to this question, Monarch. One is the dialysis population, and yes, the flu vaccine would be recommended in all end-stage kidney disease patients requiring dialysis annually, and the flu season is coming up. The Advisory Committee on Immunization Practices recommends a yearly inactivated or a recombinant quadrivalent influenza vaccine for individuals on maintenance dialysis. But keep in mind, the existing recommendations do not currently state the preference for the type of vaccine that should be administered in the dialysis patient. Now, to answer the question on solid organ transplant, yes, it is safe and effective to give influenza vaccine to individuals who have a solid organ transplant. And there is some data on this by Dr. Birdwell, who did a prospective cohort study in a single center that looked at kidney transplant patients, which is the solid line, and compared it to controls, which is the dotted line, where they checked antibody titers before and 1 month after vaccination by hemagglutinin inhibition assays for influenza type A, H1N1, A, H3N2, and influenza B. And the primary outcome that they were looking for was the percentage of patients that maintained seroconversion, defined by a hemagglutinin titer of more than 1:32. So just to give you perspective, for the influenza A H1N1, the kidney transplant patients maintained at 88.5% seroconversion, as opposed to 83% of the controls, so not difference at all. In influenza B, 81% of the kidney transplant patients maintained primary outcome, whereas 74% of controls. But when we looked at influenza A, H3N2, the kidney transplant group had only 66% maintenance of seroconversion, as opposed to 90% of the controls. However, this was not significant in an adjustment analysis. So the bottom line is influenza vaccine is very safe and effective in a solid organ transplant patient.
Thank you for that summary, Dr. Chopra. Another question that I have is what makes dialysis patients so special? And since we've recently gone through a COVID-19 pandemic, are there any learning points that we have?
Well, that is, we've learned a lot during the pandemic, Monarch, and I'm going to try and answer your questions in points. So what makes the dialysis population special is, one, dialysis or CKD was itself a risk factor to develop COVID-19. And in fact, studies have shown that being on dialysis had a 3.6 times adjusted hazard ratio of developing COVID. If you had a kidney transplant as a risk factor, you had 3.5 times the risk of developing COVID. And in terms of CKD, the risk was 2.5 times. Not to mention, they also had increased risk of mortality after a severe COVID infection. So, for obvious reasons, this vulnerable cohort was prioritized early in the global vaccination efforts. In fact, we were giving out the COVID vaccine in our dialysis units, thanks to the government that subletted the vaccine to us. Also, keep in mind this population is special because they had a varied response to the kidney disease. Now, let me give you some more context. The patients who had dialysis dependency had lower rates of seroresponsiveness compared to the general population. The response that was checked was antibodies to M protein spike. And early on in the pandemic, we had post-vaccination seroconversion data after 2 doses of the mRNA vaccine. And the dialysis patient had approximately 80% seropositivity. Now, mind you, this is lower antibody titers compared to control patients who do not have kidney disease. And transplant patients had even lesser, like 20 to 50% seropositivity. Now, the antibody titers did improve after the third and the fourth dose of the mRNA vaccine. And so, what we've learned is that they did not mount a complete response, but at least they had a response. So, despite the reduced seroconversion, there is still efficacy in the vaccine in these patients compared to the non-vaccinated patients. And that's important to know because if you were to get COVID, the mortality was much higher. So, the moral of the story is the monovalent mRNA vaccines are not recommended for primary series of vaccination. And in fact, CDC recommends one bivalent mRNA dose, followed by an additional optional bivalent mRNA dose after 60 days. And the additional doses thereafter are customized per needs of an individual risk.
Well, I think you did mention this a little bit during the previous slide, but can you tell us more about the response that the patients with a kidney transplant or dialysis have to COVID-19 vaccinations?
Yeah, so there is a varied response, and there are several studies that I'm going to go over in the next few slides. This was one study which looked at immunogenicity, tolerability, and safety of COVID-19 vaccination among CKD, dialysis, and transplant in 4 university medical centers. And they looked at the seroconversion, neutralizing antibodies, and the T cell response. And let's look at seroconversion. The dialysis patient had 99% seroconversion, which was still lesser than the healthy controls. But transplant patients only had 57% seroconversion, and their T cell response was only 16%, and neutralizing antibodies only 79. And the cohort tried to look at the specific characteristics in the kidney transplant patient, which was either they were all on mycophenolate mofetil, older age of the individual, they had shorter time since the transplant, which means they were highly immunosuppressed, and they had lower lymphocyte counts, which makes sense that if they are highly immunosuppressed, they won't mount a response. There is another study that I want to highlight, which talks about this varied response to the vaccine that looked at actual antibody titers. This is the Senkovac study, which assessed the humoral response in CKD patients, hemodialysis and transplanted 1 month, 3 months, 6 months, and 12 months. And this is a Spanish cohort. And you can see on the right-hand side that the CKD and the dialysis patients mounted a good antibody response to vaccination, especially after the third and the fourth doses. And look at the transplant patients. Despite getting all the doses, some of them had poor seroconversion even after the third and the fourth dose, which kind of tells you the bottom line is that reduced responses are not unexpected in a kidney transplant patient, which is the case with every other vaccine. But kidney transplant patients should continue to follow persistent isolation measures like wearing masks, hand hygiene, and get booster doses of COVID-19 vaccine in consultation with their nephrologist. And I also wanted to mention to you that there is a varied response in COVID vaccination amongst different immunosuppressants or regimens that have been used. So, for example, if someone has gotten rituximab, they would have a greatest impact on their seroconversion, even if the rituximab was given 6 months before. But let's say they are on calcineurin inhibitors, glucocorticoids, and mycophenolate mofetil, that correlated with a reduced humoral response, as opposed to azathioprine or mTOR inhibitors, which had a favorable response. So a strategy that was employed during the pandemic was to hold the MMF for 2 weeks. However, a long-term follow-up study revealed overall waning immunity at 3 months in follow-up. So I'll try to summarize the case 2 for you. Seroconversion rates in transplant and dialysis is low, but still vaccine is efficacious. So some protection is better than no protection. There is a varied response to COVID vaccine amongst patients with CKD, patients on dialysis, as well as transplant. And immunosuppression and vaccination should be tailored based on patient treatment regimen. So moving on to case 3, we have a 65-year-old man with end-stage kidney disease due to type 2 diabetes who has started in your dialysis unit. And on routine screening, you find the hepatitis B surface antigen is positive. He says that he's received the hepatitis B vaccine 1 week ago and wants to know why he has hepatitis B surface antigen positivity. What would you advise him, Dr. Shah?
So this patient likely has a false positive test result from the hepatitis B vaccine. We commonly screen patients every 6 months for hepatitis B, and in some cases, if they're not immune, we do screen them monthly. A false positive test usually should not be assumed as an infection and should not be treated without confirmatory testing. Now, to delve into this a little bit, I have a study that I looked up, which has a case series of 5 patients with CKD who developed a transient positive but a false positive hepatitis B antigen test, which was closely related to the vaccination. And hepatitis B surface antigen was positive in all of these 5 patients at a median of 4 days after vaccination, and a repeat surface antigen test was negative at a median of 13 days after the vaccination. And subsequently, results of the hepatitis B DNA PCR were negative for all of these patients, suggesting that it was a false positive test to begin with.
Mm-hmm.
And another study here, which has some evidence, which is based on a few case reports and a case series put together, shows an analysis to analyze the detection of the surface antigen in these patients. Amongst this evidence is a prospective study at the bottom of this table, which was conducted between January 1998 and June 2000 of de novo hepatitis B infection in over 2,400 dialysis patients who were screened monthly for a surface antigen using the standard enzyme immunoassay, and positive results were confirmed with the neutralization assay. 9 patients with a de novo surface antigen were identified and confirmed with the neutralization assay. And in 8 of the 9 patients with the de novo surface antigen, the surface antigen was temporarily related to the hepatitis B immunization. And at the bottom of this, at the top of this table, we have a study by Jansen et al. At reference at number 14, which revealed that one of the 6 patients had a detectable surface antigen for almost 20 days after the patient was immunized. So, a few learning points from this case in the next slide are that we have hepatitis B surface antigen should not be tested for at least 14 to 28 days after the vaccination to prevent any interpretation issues. And let's say if we have a patient on dialysis who ends up testing positive, vaccination history should be sought, and investigations including a repeat surface antigen and a viral load should be performed, and to rule out hepatitis B infection while the patient's dialysis machine is isolated. That brings us to our case 4, where I have a 65-year-old man who has an AKI because of multiple myeloma. He's on dialysis now and is about to get a stem cell transplant in a month. Would you have any special recommendations with regard to vaccination before he gets the stem cell transplant?
Yeah, stem cell transplant is adding a whole next level of complexity to an dialysis patient. And keep in mind that these would be the vaccinations recommended in a stem cell transplant individual. And the meningococcal and the human papilloma virus vaccine would be age or risk specific. And the antibody titers to vaccine preventable illnesses decline after someone has gotten a stem cell transplant. And the take home point here is that primary re immunization is required when the immune system is reconstituted, which would happen in 4 to 6 months. So, like in the pneumococcal vaccine, you could give the fourth dose of the conjugated pneumococcal vaccine if graft versus host requiring immunosuppression. But for all others, the polysaccharide pneumococcal vaccine 23 would work. So, to summarize this presentation, we have patients with CKD, dialysis dependency, and transplant with lower rates of seroresponsiveness compared to general population. Despite the lower rate of seroresponsiveness, there is vaccine efficacy in vaccinated patients compared to non-vaccinated patients with kidney disease. The live vaccines should be avoided in immunocompromised host, but not all end-stage kidney disease patients would have contraindications to live vaccine. Keep in mind the special scenarios, where they are getting a stem cell transplant or they are highly immunocompromised with a CD4 count of less than 200. Just be mindful of those circumstances. And a nephrologist needs to have a shared responsibility with the primary care provider to ensure that all appropriate vaccinations are administered to their patients. Now, with this, we would like to end this webinar and thank you everyone for listening to us. And thank you, Monarch, for chiming in on the cases. We learned a lot today.
Thank you.